If I told you that the question, is healthcare in this country a right or a privilege, has been an interest of mine for almost 50 years, you would probably, 1, question my honesty, 2, question my memory, or 3, you would think I look great for someone who is 85 years old. Now the fact is, I'm only 64. I am honest, and my memory is fine. However, in 1966, as a 9th grader at the Hicksville Junior High School in Long Island, New York, I had a wonderful social studies teacher named Mrs. Lambert, who had us discuss the controversial topics of the day, including abortion, Vietnam, and the rise of communism. We also discussed and debated the specific question, is healthcare a right or a privilege? So as a 9th grader, as a result of this discussion and debate, it was my strong opinion that healthcare in the United States was a right for every individual. And since that time, almost 50 years ago, my opinion has not changed. However, after practicing medicine for over 30 years, I also understand that there is a lot more to answering this question than a simple yes or no. Whether healthcare is a right or a privilege has been at the core of the healthcare debate in the United States for over a century. If one believes that healthcare is a right, the discussion then becomes one of how to provide universal coverage. The Affordable Care Act, or ACA, is the first law to define healthcare as a right and has moved us strongly in the direction of universal coverage. Since universal coverage is the theme of this discussion, let me start by giving you my definition. For me, universal coverage describes a system that provides healthcare and financial protection for everyone. That was the easy part. The hard part is developing a system to achieve it, and that will be the substance of this talk. You may be surprised to know that the healthcare debate in this country did not begin in 2010 with the ACA. There is a more than 100-year history of unsuccessful attempts to provide universal coverage for all Americans. I think that understanding the past allows us to better understand where we are, where we're headed into the future. So let's begin. Let's start in 1915. The first legislation was introduced to provide health insurance coverage for the working class and those who earned less than $1,200 per year. Then World War I happened, followed by the strong post-war anti-communism movement. Since universal coverage was a concept that was considered communist, this legislation went essentially nowhere. In 1933, FDR began his first term with a focus on developing a proposal for unemployment insurance, benefits for older Americans, and health insurance. The AMA, the American Medical Association, opposed the health insurance component, so it was dropped in an effort to get the legislation passed. So the Social Security Act of 1935 was passed without any health care insurance coverage. Now, FDR tried again in 1943 with legislation for national health insurance, but he died before any substantial progress was made. President Truman indicated his support for a single-payer system for all Americans. This plan was opposed by the AMA, the American Hospital Association, and the American Bar Association. This is the trifecta, as I like to call it. When have you ever seen the AMA and the American Bar Association agree on legislation? Strange bedfellows, to say the least, and they say politics makes strange bedfellows. This was a great example of it. Now, of course, this legislation never made it out of committee. Now, the early 1960s brought efforts to cover hospital costs for the elderly on Social Security. This time, the AMA advocated that physician fees should be included in this elderly insurance. A compromise bill covering hospital expenses and physician fees for the elderly and the indigent was passed as the Medicare Act of 1965. Now, at that time, no one could have predicted the dominant role this legislation would play in the provision of health care in this country. In the 1970s, Ted Kennedy, a Democrat, advocated for a single-payer system. President Nixon, a Republican, also supported health insurance reform, so there was clearly bipartisan interest, but clearly no agreement. President Clinton tried again in 1993, with Hillary taking the lead. The Health Security Act was complex and quickly met resistance from Republicans and the health insurance industry. Remember the Harry and Louise ads? They were very effective, and any efforts at healthcare reform failed. Now, an important takeaway point from all of these attempts to develop national health insurance is that regardless of whether they were supported by Republicans or Democrats, they shared common characteristics. 1. It included an employer mandate. This was usually the centerpiece of the proposals. 2. An individual mandate. Now, this was needed to guarantee a balanced risk pool. 3. Cost sharing. An important characteristic, since increased individual responsibility for the cost of care results in important accountability with respect to the utilization of resources and possibly even lifestyle choices. 4. A defined benefits package. Basic benefits that must be provided by all healthcare plans. 5. Subsidizing the poor who could not afford to fulfill the individual mandate. 6. Tax-deductible health benefits. This was particularly important for employers who would be providing much of the coverage of people in this country. So by 2009, healthcare costs in the United States represented 17.6% of the gross domestic product, and nearly 50 million Americans were uninsured. The election of President Obama, followed by the passage of the ACA, ushered in the most extensive healthcare reform we have ever experienced. Simply stated, there were 7 core components of the ACA: individual and employer mandates for insurance, guaranteed coverage for pre-existing conditions, minimum standards for health insurance plans, establishments of health insurance exchanges, subsidies for low-income families to obtain insurance, expansion of Medicaid eligibility, and lastly, cost containment and quality improvement measures. Sound familiar? Of course it does. The major components of the ACA represent reformatted and recycled components of the national health insurance plans that were proposed by Republicans and Democrats over the previous 50 years. What made the ACA different was that, unlike all previous efforts, the legislation made it out of committee, was brought to a vote in both houses of Congress, and was passed, even though the vote was entirely along party lines. Although lacking bipartisan support, the ACA did become the law of the land. So let's examine the Affordable Care Act more closely. The ACA basically expanded the current system of coverage to uninsured Americans by expanding the public-private partnership of health care coverage already in place. Eligibility for public programs was expanded, and new products were offered by the insurance industry through state and federal exchanges. Now, we could discuss the details of what was included in the ACA and what wasn't, but it is more important to recognize that the foundation of the legislation is the expansion of the public-private partnership. That has been the backbone of healthcare coverage in this country. This approach has resulted in an additional 16 million people now having healthcare coverage compared to 2009. This number continues to grow in spite of the many logistical issues that impacted the exchanges, delays in implementation of specific components, and the ongoing opposition to the healthcare plan. Now, for those who support universal coverage, the ACA is certainly moving us in the right direction. However, now that the ACA is in place, the question for me becomes, what can we do to assure universal coverage and at the same time have a positive impact on the health of Americans and the cost of health care in this country? This is where I get my chance to design the next iteration of health care coverage in this country. So let's start by understanding some basic definitions, beginning with entitlements and benefits. An entitlement is a government program that guarantees access to a benefit based on established rights or by legislation. Both Social Security and Medicare are entitlement programs whereby individuals are entitled to participate by law. Now, a benefit is a program for which individuals may be eligible based upon specific criteria, like employer-sponsored health insurance, where eligibility is based on your employment status. We also need to understand the concept of means tested. This approach uses an individual's annual income to determine eligibility for a benefit or an entitlement. So now let's return to our goal of universal coverage. With these definitions in mind, let's change the question, is healthcare a right or a privilege, to, is healthcare an entitlement or a benefit? In my opinion, Healthcare in this country is an entitlement. However, it should be a means-tested entitlement for all individuals. Let me explain what I mean. In my system, every individual is provided with basic healthcare coverage. This coverage will be provided by employers, by government programs like Medicare and Medicaid, and through health exchanges just like we do now. Means-tested government subsidies would continue to be available to offset the costs for those who have to purchase their own insurance. In this system, each individual would have the option of expanding their basic benefit package by using their own resources. In other words, purchasing additional expanded coverage. An essential component of this plan is for everyone to have the basic benefit plan to avoid being underinsured and thereby avoiding medical bankruptcies. The definition of this basic benefits package will be an important step forward for healthcare in this country, since it will define the minimum coverage that everyone will have, something that has eluded us thus far. Now, this approach is just the first step. To truly achieve healthcare reform in this country, more important changes are needed. Changes that would impact the cost of healthcare and the health of the population. Now, this is where it gets more difficult and potentially more contentious. There are 5 changes needed, in my opinion. 1, Medicare should be converted to a means-tested entitlement. 2, we have to create a system that supports greater personal responsibility and accountability for one's health. 3rd, a larger share of the premium revenue of the health insurance industry should be spent on healthcare and not administrative costs or profits. 4, reforming the medical liability system is necessary to reduce the unnecessary diagnostic tests and the practice of defensive medicine. And 5th, we need to restructure the costs of medical school education. Now let's consider each one in more detail. Converting Medicare to a means-tested entitlement means that those individuals over age 65 with greater personal resources will contribute more to the cost of their health care than those with fewer resources. Currently, the retired CEO of a Fortune 500 company and a retired factory worker are both entitled to Medicare and have the same responsibility for deductibles and coinsurances, since each one contributed to the Medicare pool during their working years. Now, is that fair? I don't think so, and I think most people would agree. If Medicare became a means-tested benefit, it could result in a significant change in the cost curve of health care. Increasing individual accountability for health maintenance would be a major shift in policy and in attitude. This would require each individual to have a greater investment in their health, not just their health care. Systems should be developed to reward those who take responsibility for their health, such as not smoking, maintaining their weight, taking their medication, and remaining diligent about preventive care. Benefits could include reduced premiums, smaller deductibles, and smaller coinsurances. Now, conversely, those who are not focused on their health should bear greater responsibility for their health care costs within the context of their personal resources. This concept is already in place by many self-insured employer plans and has resulted in a reduction of medical expenses. Now it needs to be expanded broadly across the public-private partnership. Ensuring that a large share of the insurance industry revenue is spent on health care is already a part of the ACA. Commercial insurers are required to spend at least 80% of premium revenues on clinical benefits. However, we should move this even further. Why not 85%? Why not 90%? Even with these changes, rest assured, the commercial healthcare industry will remain a very much for-profit industry. Medical liability reform should have been a part of the ACA, and a great opportunity was missed. A federal measure to enact national liability reform would have a tremendous impact on the cost of healthcare that would go beyond decreasing the cost of malpractice premiums. The cost of our current medical liability system, including defensive medicine, is over $55 billion annually and increasing. Medical liability reform would have the direct benefit of decreasing the cost of care provided just by reducing unnecessary testing. However, the indirect benefits would also be significant, including the impact on the physicians who often feel beleaguered by the shadow of malpractice concerns as well as the high cost of liability insurance. Imagine if all of this energy could be devoted to the patient-physician relationship instead. That is an outcome we could all support. In the system that I am describing, a change in the current model of medical education should also be a part of achieving universal coverage and establishing a system of medical care for the future. Now, as universal coverage becomes a reality, patients will no longer use the emergency room for routine health care, but will be seen in physicians' offices and clinics. There will be an increasingly greater need for primary care physicians to treat all of the new patients with health care coverage. One of the most significant issues that deters medical students from pursuing primary care specialties is the increasing debt, often greater than $200,000 by the end of medical school. This has led medical students to choose specialties with greater compensation to assure a faster payback. To address this problem, the federal government should pay the tuition of all medical students attending a U.S. medical school in exchange for a period of service at the end of residency training. This would address the projected physician workforce shortage as universal coverage becomes a reality. With an average annual tuition of $45,000, the cost of tuition for the 20,000 medical students entering medical school each year would be less than $1 billion per year, equal to less than 0.002% of the annual Medicare budget. If developed carefully, the benefits of this approach could be a true game changer. By this time, I think you get the idea that I support the goal of universal coverage. If you don't get that, then you probably haven't been listening. For me, healthcare coverage is a right, not a privilege. Now, the ACA has established a plan to move us closer to achieving this goal by building upon our current system. Although not ideal, it was the best option available. Now, I have suggested more significant changes in our system of healthcare coverage. To me, comparing the current ACA and my suggested approach is like comparing two plans to renovate your house. So let's take this scenario. Suppose you have a home that seems just fine for you and your family. You live in a nice house, one that looks just like this. But then life changes, and you need to make room for your in-laws who are ill, as well as your daughter and her 2 children because your son-in-law is not working. Now you need to accommodate more people than before, kind of like expanding your coverage. You have no choice. You have to renovate your house and make it bigger. So you use the existing footprint and the available land and create more space by building up and out, as much as your finances will allow, something like this. This is what you come up with. Not perfect by any means, but the best you could do with the available resources. Kind of like expanding the already existing public-private partnership of healthcare coverage. This renovation may accommodate the additional people, but it is really a missed opportunity to change the structure and plan for the future. The better renovation would be something like this. Acquire land adjacent to the property with a larger footprint and build a more extensive structure with space for current and future needs. The ACA completed the first renovation. What I am suggesting is the second renovation. That's the one that is needed and will provide a far better long-term plan. Now, the 5 changes I have proposed would provide the foundation for this second renovation. Can we make these changes? That remains to be seen. It certainly would not be easy, especially when you consider all of the special interests involved, including insurance companies, physicians, the pharmaceutical and medical device industries, hospitals, and most importantly, patients who have continually shown a reluctance or refusal to change the healthcare benefits they receive. If healthcare is truly to be a right in this country, it is clear that more significant changes are needed. Coverage cannot be provided in a vacuum. It should be part of a plan that significantly changes the slope of increasing healthcare costs and ultimately decreases the cost of healthcare in this country. It should recognize and reward the value of a healthy lifestyle and also recognize the importance of having each of us assume a greater responsibility for our health and the costs of our healthcare. In some ways, the case for universal coverage is a simple one. It represents the moral and ethical approach in a country that is known for taking care of its citizens. However, to effectively obtain universal coverage, changes will be necessary in our approach to providing health care and medical education. To accomplish this, all of the key healthcare stakeholders in this country will need to be both innovative and be willing to compromise. Time will tell if this will be possible. And one more thing about Mrs. Lambert. When it became evident to me how influential her social studies class had been on me, I made an effort to contact her. I wanted her to know that discussions she initiated as part of her curriculum in 1966 proved to be very important almost 50 years later, and at least one of her students was greatly appreciative. Unfortunately, when I tried to contact Mrs. Lambert, I found out she had passed away. But I was able to share my appreciation with her husband and family. That was very important to me, but I only wish I could have told her myself. Thank you very much for listening.